to Let's Talk Menopause, Menopause Talk. My name is Donna Klassen. I am the co-founder of Let's Talk Menopause, and I'm here with Dr. Robin Noble, and we are going to answer your questions. These menopause talks are central to our education efforts, and you can watch the past 20 or so on our website. Just to give you a little medical disclaimer, all of our menopause talks are intended for informational purposes only, not for as a substitute for direct medical advice, diagnosis, or treatment. So just make sure that you check in with your own medical professional. We have disabled the chat and we'll be only using it to provide you with relevant links. You can answer all your questions on the Slido app. You should see a prompt at the on your screen. And this is the first time that we're using Slido, so hopefully it will go well. There will be a brief survey at the end, and we ask that you complete that as well, and that will also be through Slido. So we are thrilled that we are joined by Dr. Robin Noble. Dr. Robin Noble is Let's Talk Menopause Chief Medical Advisor and practicing gynecologist with over 20 years of experience with a specialty in menopause. She completed her undergraduate work at Yale, her medical training at Columbia, and her residency and fellowship at Yale. She's a certified menopause provider through the Menopause Society, and she's board certified in lifestyle medicine. She also recently completed her master's in healthcare delivery science from Dartmouth. So we have a bunch of the questions already in the chat in Slido, so we know sort of a lot of the questions are going to be on hormone therapy. But one of the things that people always ask us is how to find a provider. So why don't you just sort of talk to us a little bit about that first, Rob?
Perfect. It can be so challenging to find somebody really in any area of healthcare right now, as everybody's probably aware, access is really limited in so many fields. So that's one of the issues we all face. You know, even if we find a doctor, we get into a doctor, they take our insurance. It depends if it's kind of a fit and you feel, listened to and you feel connected and you feel open enough to share some of your, kind of more intimate questions. So that's, kind of first and foremost where we even start. And then, somebody's level of not only expertise in the area of menopause, but also their interest level really matters. We can see providers in all different fields, whether they're, allied professionals, nurse practitioners, physician assistants, social workers, and even CNMs can have a special interest in menopause, and even internal medicine doctors, family practice doctors, and even OBGYNs. But there isn't a standard pathway. I would say it's more right now kind of a passion and interest and expertise. And I agree that that's not at all adequate. We need to, put the bar a lot higher, that there needs to be a basic understanding, a basic familiarity with the menopausal transition, the various impacts on all of our different organ systems, but also the treatment options. So I understand it's a challenge. I think one of the easiest ways to kind of suss out someone's willingness and ability is to come right out and ask someone if they feel comfortable managing menopause, talking about issues related to menopause, sexual function in midlife, mental health issues. And I think right off the bat, you'll get an idea whether that person is well-versed. And it can be, it can also be a nice way of saying, do you feel comfortable managing this, or do you think I need to see a specialist? And that's what I generally recommend, Donna. I know you and I have also talked about sometimes if people feel dismissed, that's a red flag. If people feel that, everything's being written off as normal and it should just be tolerated, I think that's a red flag. And then I always caution people that if anybody is selling something and has, they're profiting off either a subscription plan or they're selling medications or supplements, that's a red flag to me, because it worries me that it's ethically dubious if they're making money off of their practice in a way. So those are some of my hints. And apologies if my dog made some noise in the background.
No worries. And it is really hard to find menopause providers. We know that, and that's why we're doing these series, and that's why we exist, to get more providers trained, to make sure that people get the information that they need, and science-based information, because I think that's really important. So let's go to the science, because again, so many of the questions are about hormone therapy. So if you can just give us like a brief summary, and I know it's really hard to do a brief summary about hormone therapy, but if you can just sort of give us a little bit of the history and just lay the land for hormone therapy.
Yeah, and one other thing I would add here is what I'm seeing in healthcare in general right now is we all have so much access to information. It's really hard to sift through what's valuable information and trustworthy information, but we can become experts in many ways in so many different areas. And anybody who has access to the internet can do a whole bunch of reading before they come into a visit. And some healthcare providers can be threatened by that because if somebody has a very unusual thing, that person might come in with actually more up to the minute research. So I think that's something we all have to be aware of, that information and rapid changes in information make this challenging, and people have to deal with that, particularly healthcare providers, with humility and understanding and recognize how to manage that information. But the science has not really changed so much as the interpretation of the science. So this big study in the early 2000s really was looking at an outcome of whether hormone replacement therapy would be helpful to prevent cardiovascular outcomes. And what happens in a lot of medical research is we need enough people, like a sample size that's large enough that is likely to have, say, a heart attack or a stroke. So what they did is they primarily looked at older women, and the average age was 65. And because that age was much older, some conclusions were made that perhaps combination hormone replacement therapy, that we now have kind of dubbed menopausal hormone therapy, but when we talk about hormone replacement therapy, menopausal hormone therapy, we're kind of talking about the same things, that increased the risk of clot or stroke when people started in an older time. Now we're actually recognizing that it's very different to consider hormone therapy around the time of menopause. And in fact, there are some clear benefits in starting things early. And it's really maybe problematic and increases our risk when we start it later. So I'm happy to get into that. But I would say that's the premise of why this has all changed, is there's now an understanding that hormone therapy around the time of the menopause transition is very different from starting hormone therapy when someone's 65 or 70. Does that help?
Yep, that does help. And can you explain the difference between systemic and local hormone therapy?
I find it's helpful to kind of break down a couple categories. So I'll do that right now too. So local therapy, when people have local vaginal symptoms, vaginal dryness, pain with sex, sometimes irritation, sometimes urinary urgency or frequency, and even an increased number of urinary tract infections, as well as sometimes a sense of pelvic pressure or prolapse or descent. Vaginal estrogens and similar compounds, so estrogens and a few other compounds given locally to the vagina, can be really helpful with those symptoms, and they don't get significantly absorbed to impact breasts, our breast cells, our brain, our vasculature, and our bone health. So it's designed, and there are various things that are designed to be local and just local, if that makes sense.
Mhm.
And there's one other compound that's actually one of these, what I tell people are kind of fancy estrogens, that's a tissue targeted medication, osfena, that's an oral medication, but it's really designed to be basically vaginal tissues, and it does have some impact on the bone. That's the only one that has kind of an oral route designed for the vagina alone. The other ones tend to be creams, little pills, suppositories. There's even a ring. And so there are various things that are designed and really aimed only at the local vaginal urogenital syndrome of menopause. There's a new term that you can see on our site too, genitourinary syndrome of menopause, that encompasses all these local vaginal symptoms. Then when we talk about systemic, or I tell people it's kind of whole body hormone therapy, that's aimed at getting blood levels or serum levels so that those hormones can impact brain, vasculature, cardiovascular system, our bone health, and even the hot flashes and some of the other symptoms, as well as even mood symptoms that people can experience, as well as joint and other things, as well as we think there are significant changes in the immune system. So sometimes people notice more kind of inflammatory symptoms, and those ones you would want to be looking at whole body therapy, if that makes sense.
It totally does.
And
So
then,
we're going to start with a question. Go ahead.
no, I was just going to say, and then another point of confusion or commonly misunderstood is, why do sometimes people talk about estrogen and progesterone, and sometimes people talk about just estrogen? And, oftentimes I find my patients really, need to dig in and understand this. And we will obviously help debunk some of this stuff. But the confusion will arise because estrogens are only needed when someone's had a hysterectomy. And estrogen and progesterones, this is for systemic treatment, is needed when we have a uterus with, kind of one exception. And that is because progesterone, we believe, is really important. And we've demonstrated this, over decades, really important to protect the endometrial lining. So we need that progesterone to counteract the effect of estrogens only on the endometrial lining. So if that helps people understanding kind of estrogen alone, and that data is quite different for those people when they've had a hysterectomy, and estrogen plus progesterone. And this is, again, talking whole body. Everybody, virtually everybody, is a good candidate for that local therapy of some sort. Even people who have survived breast cancer, we have ways of mitigating those local vaginal symptoms in very, very safe ways. But the whole body stuff is kind of a different category. And then divide the whole body stuff into estrogen alone and estrogen plus progestin, with one exception of one of these fancy compounds.
Got it. And then just so everyone knows, with local vaginal estrogen, you do not need progesterone because that's a local therapy. That is just estrogen alone. Okay. So we're going to start, actually, somebody had a great couple part question. And this is when, perimenopause is when women have a lot of symptoms. And this is when hormones go up and down, up and down. I mean, they're just like this, right? And so I still get confused about this, about what to do. And I've been talking to you and all these other doctors. And so Sarah asked this question: is the birth control pill more appropriate than HRT to treat symptoms during perimenopause? Does the pill count as HRT for all the other benefits to your brain, et cetera? And then the second part of it is birth control more appropriate? I thought estradiol is more common in patches, so why would I also be prescribed birth control? Also, birth control has synthetic progesterone instead of bioidentical. Okay, there's a lot of different questions. So we'll start with just her first question.
Right. And remind me if there are a couple other ones, because this one, if I remember, has like 4 or 5 parts to it. Yeah. So one of the biggest challenges is treating perimenopause can actually be far more complicated than treating menopause and the menopausal transition, because, as you mentioned, our hormone levels physiologically do these kind of roller coasters. And with those roller coasters, people can have a whole host of symptoms. They can have symptoms when the estradiol is really, really high in the progesterone, and they can have irritability, mood symptoms, almost heightened PMS, breast tenderness, bloating, a whole host of symptoms. And then when that estradiol really falls, they can have almost what I say is almost a window into menopause, where they have hot flashes, they have difficulty sleeping, they can get menstrual migraines, they can feel really fatigued. So they have both the highs and the lows. And in somebody who is a good candidate for oral contraceptives or the equivalent ring or even a patch, the reason that can be so useful is it's really one of the only things that mitigates this roller coaster. Because when we use a birth control pill level dose or a ring or a patch, it basically gives us a steady state, same hormone level all the time. So somebody who's really suffering from those roller coasters is really better managed by suppressing our own ovaries, because it's our own ovaries that are doing this. So you need a higher dose to suppress that, right? And when someone goes through menopause, their hormone levels are really, really low, and you just need to kind of bring up that floor just a little bit. So indeed, if someone's suffering from all those symptoms of perimenopause, they will likely fare better on a very low dose birth control pill that will suppress their own kind of what we call endogenous, or our own hormones, override that and kind of give us a steady state. And if we can do that, because they don't have any contraindications like being a smoker or having hypertension or having very concerning atypical migraines, you can successfully give them the same hormone every day and basically avoid that perimenopausal roller coaster. And that can work beautifully. And you're right in that there isn't these kind of biosimilar agents. There isn't a natural progesterone in that kind of dose. There isn't an estradiol in that dose. And if I had my druthers, we would have birth control pill level doses in those compounds, but we don't. And birth control pills work really well. And yes, they will give you those same benefits. And in fact, one of the areas that's really important is going through menopause or that menopausal transition, or even experiencing perimenopause really early, is not good for us, because it actually has been shown to increase our risk of osteoporosis, cardiovascular disease, colon cancer, and probably all-cause mortality. And so what we know is someone who's really experiencing these roller coasters, or they're skipping cycles for a period of time, or they even go through menopause at earlier ages, we should have them not only on hormone therapy, but there's evidence that they should be on more of birth control pill level doses. For their bone health and other reasons, we actually want them on a higher targeted rate. So really good question, really nuanced information, but yes, birth control pills can be incredibly helpful. They can override that system. They can provide what we really feel is that adequate level of hormone that we need for bone health, vaginal tissues, cardiovascular health, and you get all of those benefits. I think I maybe hit all of them in the
I think
bioidentical.
you might have, but I have a question just to follow up on this. You could also do birth control pill and then an IUD for the progesterone.
Well, you might not even need that. So we've got a lot of, I tell my patients, like sometimes I have a lot of tricks up my sleeve, because the IUD can work beautifully for the bleeding, and that protects the endometrial lining. And I use that in hormone regimens as well. And sometimes you can use an IUD to protect that endometrial lining and skirt by with a really low dose birth control pill, which without that IUD, sometimes people get some really annoying spotting. So I tell them that sometimes really low doses, where ordinarily we might have a lot of spotting, and an IUD can work really well. But I also wanted to mention for those people who really can't use birth control pills, because I have a lot of patients like that. They either are smokers, or they're hypertensive, or they have higher cardiovascular risk. And in that case, we try to kind of mitigate those lows, and you can put a low dose patch for that week where they have sleep issues and hot flashes and migraines, and you can treat them with a low dose or like a physiologic patch. And then you can treat some of those hormones from the really high peaks with, as you would know, Donna, like SSRIs, SNRIs, some of the mood medications. So you can help with the irritability up here, and you can help with the lows. You can't override the system because they can't safely use birth control pills, but we try to kind of piecemeal and work on the various symptoms. So there's really treatment for so many of these symptoms, even if we really need to tailor it to someone's particular medical issues or even their preferences. I have patients that philosophically, they'd rather not be on mood medications, or philosophically, they'd rather not be on the birth control pills. And we can use things like higher levels of natural progesterones can kind of suppress some ovulation and mitigate some of those symptoms. So we've got a lot of different ways to tweak this, but it gets really complicated. There is not a one size fits all approach for people.
Right. I know everyone probably on this menopause talk is saying, how can I get you as a doctor? Because I think that's one of the things, right, is finding someone who knows all these different things. And that's part of the problem, right? I'm going to continue. She has one more part of the question from cedarsinai.org. When started before, when HRT hormone therapy started before a woman reaches menopause, HRT reduces the risk of this fuel switch and can cut a woman's Alzheimer's disease risk in half. Once a woman reaches menopause hormone therapy no longer appears to have this brain protecting effect. I think we don't know the answer to this. Yes, I think, right. I think the research
I'm happy to speak to it. I think you're absolutely right. It's very muddled right now. We're desperately in need of some research about the role of hormones in the brain, and particularly hormone replacement therapy. That there's some data out of Denmark, and Dr. Lisa Mosconi is probably the preeminent researcher right now in hormones in the brain. And there is some concerning evidence that perhaps menopausal hormone therapy, when estrogen and progesterone is required, could potentially increase our risk of dementia. It might be neutral, whereas estrogen alone seems to decrease our risk of dementia. But I think what the question's really getting at, and this is what I wanted to speak to, is the symptom of brain fog. And so when people get brain fog, and it's really severe, there seems to be some early evidence that treating that earlier with hormones seems to be more protective. But if you don't get to it soon enough, and someone say 3, 4, 5 years into menopause, you might not have that same protective benefit. So without having adequate research, I often kind of extrapolate what we understand and what we know. And what we think happens is that the blood flow to the brain changes a little bit. And if that's happened for a long period of time, we might not be as good at revascularizing some of those connections. However, we also know that there are times in a woman's life when, say, she's postpartum or she's breastfeeding, and she experiences low levels of estradiol, And there's a lot of remodeling that happens. So what I would do is tell somebody, I don't want them to be really worried that there's this time switch, fuel switch in a 3 or a 6 month or a 9 month. But I think people need time to experience their symptoms, figure out how bothersome they are for them individually, decide what they're open to, consider trials. And this data kind of tells us, yeah, we should do that sooner rather than later. We shouldn't suffer for a couple of years. So I think that awareness is helpful, but beyond that, I don't think we have the specific data to answer the questions, if that's helpful.
Right. And we do have a menopause talk on cognitive functioning that was really good. It's on our website. Okay. So from Anonymous, what levels, she asks, or he asks, what levels should your estrogen, testosterone, and progesterone be? Or is it patient specific?
It's so patient specific. And actually, we don't think, and the Menopause Society doesn't feel that we should need to do a whole lot of testing. And I agree with that in theory. I think we're really treating to the person. And so, for example, if I use doses of menopausal hormone therapy and I have to pick a place to start, I'll often tell people, look, if we're a little on the high side, you're probably going to feel breast tenderness, maybe a little bit of emotionality, irritability, maybe a little headachy, and that will tell me that like maybe we need to go a little lower. On the flip side, if I start you somewhere and hot flashes are better, sleep is better, but you're still not really feeling where you want to, maybe we need to bump up a little bit. And so hormone levels doesn't really help me do that. And we don't have guidelines in general for the general population where we're targeting to a specific place. There are situations where we might aim a little higher. I'll give you one just as an example. Somebody that I am managing that has really severe osteoporosis already, right around the time of menopause. And there's some evidence that a slightly higher level of estrogen is probably more bone protective. So in her, we did manage, we did decide to do a couple levels to just make sure targeting, we were a little closer to 60, 70, but usually we don't use them. Testosterone is an exception though, and we can maybe dig into testosterone a little bit more. And that is the one area where we feel testing is indicated. Now, I'll tell you, it doesn't really correlate with our libido, our muscle mass, the other symptoms that we attribute to testosterone. So I can have somebody at a really low normal level that doesn't feel these symptoms at all. And I can have someone at a quite robust level that is complaining of decreased libido. But the rationale for testing is that if we are treating someone, we want to keep them within that physiologic range, because there's evidence that testosterone can increase our cardiovascular risk, as well as kind of increase hair growth, permanent deepening of the voice, and some central hair loss. So when we treat with testosterone, that's the one area where we want to know where we are. And we want to kind of have a target rate and be able to adjust that so we're not overdoing it and causing some adverse side effects that could even be permanent. Does that make sense?
That totally makes sense. Before the next question, I'm just going to go back to that original question when talking about perimenopause and hormone therapy. How then do you know if you've gone, I guess, you're in menopause, right? If you're on the birth control pill, how do you know?
Yeah, that's a really good question. I tell people we don't know. We have to guesstimate. So we sometimes use some family history if it's available. We sometimes use the average age is 51, 52. If someone's doing beautifully on birth control pills, I'll often say like somewhere between 52, 53, we might trial you off. If you want to see how you feel, that's an option. If someone wants to kind of segue down to hormone, like menopausal hormone therapy, we'll often do that. And I'll explain that then we're not blocking their own ovarian function. So if all of a sudden they start cycling every month, we go, oh, nope, too soon. They're still cycling. So we have to do a little bit of guesswork and a little bit of testing. But one other thing I wanted to get back to about that hormone testing, because I think this is a question that comes up a lot. An awful lot of people are kind of selling testing and pandering testing and saying you should have a hormone test. And it's usually really not helpful for us to predict when menopause will be. It's, there's so many limitations that we use it if we're confused and we need to answer a question. Like with my osteoporosis patient, or if someone has a Mirena, they're not bleeding at all, they're having a couple symptoms and we just don't know, are they menopausal or not at all menopausal? So in that setting, they can be helpful. And oftentimes we have to check the thyroid, because the thyroid can kind of, mimic a lot of the symptoms of weight gain, fatigue. So thyroid's often indicated. If we're confused, they're indicated, but I wouldn't fall prey to people doing all this testing and saying your progesterone's high, your estrogen's low, your testosterone, because it's not helpful. It
And
just costs a lot of
because
time.
in that perimenopause, it goes like this anyway. So on one day it might be this, and the next day it might be this.
People are marketing these Dutch tests and they're taking thousands of dollars from people, then really trying to convince them to do some of these custom compounded things that aren't really backed by the Menopause Society and that are, I would say kind of ethically dubious. So just let the buyer beware. You want to find a trustworthy provider. Anybody who's ordering a lot of tests, selling a lot of things, try to just have your eyes open.
Okay, great. Okay, so Anonymous just asked, I'm 59 years old and have had menopause symptoms for the past 8 years and still have the symptoms, your general symptoms and low libido. Is HRT an option at this stage? I guess we don't really know when she went through menopause, like when her final period was.
I think she said 8 years of symptoms. Did it say 8 years?
8 years of menopausal symptoms,
Yeah.
but so she's 59. So
So she's still, a lot of people will hear these guidelines from the Menopause Society of kind of under the age of 60 and within 10 years of transition. And these are, again, just guidelines. They're not written in stone, but it comes back to that understanding that earlier is better and later is less good and perhaps problematic, depending on how old we are. But I would say kind of officially, she is, under the age of 60, she is within 10 years of menopause. The options are available to her if she were my patient. Absolutely. I would say we want to be mindful, and this understanding of this timing hypothesis, why we think it's important, is that in those ensuing 8 years, we develop some more cardiovascular disease. And it's in those 8 years that then we worry if we've developed some cardiovascular plaques and we start hormone therapy, that from what we learned in the WHI, we could be potentially increasing someone's risk of cardiovascular disease, a heart attack, or a stroke, particularly in the first 6 to 12 months. So in a patient like that with me, we'll look at lipid profiles. We'll even do what we call an ASCVD risk or atherosclerosis test and cardiovascular disease risk profile. So if that person's lipid profile looks really favorable, they don't have high blood pressure, they're not a smoker, and they're in really good health, then those options are available to them. If someone has much higher risks and they might have some pre-existing cardiovascular disease, I'm going to be less enthusiastic because I don't want to increase their risk. Now, the testosterone piece was also asked. There isn't that same known time frame with the testosterone. So I would fall back on the fact, again, cardiovascular disease risk is important because testosterone seems to slightly increase our risk. So in somebody like that, I think a testosterone level is reasonable. If someone has bothersome decreased libido, that's the indication for testosterone. And if their testosterone is kind of, low normal and they want to do a trial in a very judicious way, that's available to them as well. So I would tell that person, all the options are available to you, but as always, it's kind of that risk benefit profile. What is that person's risk of osteoporosis? What are the other treatment options we could consider? What is their sleep like? What else are they doing? And I really think you need to look kind of through all those symptoms. Are there other options? Is this what you want? Do you want to try this? Are you a good candidate? Does that help?
Yep, it totally helps. She had another question, but I lost the second part of the question. I believe I know what it was, though. It was about osteoporosis. And just so everyone knows, you lose, I guess, 20% of your bone density in those first 2 years post-menopause. And she asked a question about what else you can do to sort of
that high. I mean, we think maybe 10% of our vertebral bone mass in the 5 years surrounding menopause. I mean, it's going to vary with the person and what their other medical issues is, but certainly we kind of fall off a cliff with menopause. And this is an important piece too that sometimes people don't hear. If someone is doing menopausal hormone therapy for say 5 or 10 years, and then they stop it, our bones kind of fall off a cliff too. So we want to be mindful that any of those changes really impact our bone health and what's happening with our bones in those next few years.
Okay. She had another question just about what you can do besides weight bearing exercises, but I'm going to refer her to our last menopause talk on our website, was a bone specialist. And we'll come back to it if we can, but I just feel like we have a lot more questions. So unless you wanted to say something about that, Robin.
Well, I was going to say that's a really important discussion too. If someone says, I don't really want to do bone medications, and maybe I'm still a candidate for menopausal hormone therapy, we know it's not treatment for osteoporosis, but that's one of the indications for menopausal hormone therapy. It's extraordinarily protective for bone health, and people need to be aware of what their risks are for bone, osteoporosis and bone issues, as well as cardiovascular disease, as well as breast cancer, which is a common concern. And people are wondering, what's my average risk of breast cancer? What's my average risk of cardiovascular disease or osteoporosis? And I think the more we're empowered to look at ourselves holistically and what our next chapters and the next almost half of our life, that's where it really is important to weigh these risks and benefits.
Right. To not just look at breast cancer, to not just look at bone, it's the overall risk, right, of everything. And so I think that's something that we've really been talking a lot more about, is these long-term health risks of not getting some treatment from hormone therapy, right? And what that looks like. And then the other thing is, there was just something else that I thought of and I can't remember it now, just about bone density. But we'll move on from it and continue. Anonymous, how long is it recommended? The question is, how long is it recommended for a woman to stay on hormone therapy?
There really isn't a recommendation right now. And I would say this is really getting reframed, because previously, even, within the last 5 years or so, the Menopause Society used to say the lowest possible dose for the shortest period of time, which I personally never really subscribed to. I tell people I think it's the most appropriate dose. Like, if we're going to be treating it, we want that most appropriate dose that's in line with that person's philosophy, where they want to be, for the most appropriate time. We now have evidence that there are probably some significant health benefits and probably less risk doing it for 5 to 10 years or upwards to the age of 60. We're starting to get more consensus amongst experts that there might even be more health benefits than risks doing it up until the age of 60. Then you hear 60 as a time frame where a lot of people will revisit, do I want to continue? What are those risks and benefits? Again, doing that very individualized approach. And if they either trial off, still have miserable symptoms, they might choose to continue. And I have some patients in their 60s, 70s, 80s, and 90s that continue hormone therapy. And I will distinguish the fact that estrogen alone is a lot less controversial than when we require that progesterone. And that gets, a little nuanced, because there are some of these new compounds, that basodoxifene with Premarin, that is kind of that fancy estrogen that doesn't require a progestin for somebody who has not had a hysterectomy. So sometimes I'll change my patients over to the trade name as Duavi, or I'll change them over after 5 to 10 years if they're concerned about that breast cancer risk or even the dementia risk. So they're changes we might make. But there isn't a set rule. There isn't a set time. It depends on the person and their wishes and their risk factors, again, and what their preferences are.
Mm-hmm. Mm-hmm.
And the local vaginal estrogens we talked about should probably continue indefinitely. There are no risks to those. So you should not be suffering from vaginal dryness, pain with sex, urinary urgency frequency. And there's evidence that it decreases our risk of urinary tract infection by about 50%. So the local ones should stay. And if somebody stops the systemic, they should likely start those, and those should continue indefinitely.
Well, this leads us to our next question from Anonymous. I have a maternal family history of uterine cancer. Is local estrogen treatment appropriate for someone with this family history?
It absolutely is. As Donna mentioned early on, it doesn't stimulate that uterine lining, so it's not going to increase someone's risk of endometrial cancer. Now, if we have an endometrial cancer survivor, even if they've been treated surgically, we're often a little bit more conservative about how we use those local options and lower doses, similar to breast cancer survivors. But if someone has a family history of endometrial cancer, that does not prevent them from using local, number one. But there's been some emerging data that's really important. Number one, that progesterone IUD, that Mirena or levonorgestrel IUD, has been shown to decrease our risk of endometrial cancer. So that can be a very proactive choice for somebody. And there's even some emerging data that menopausal hormone therapy actually decreases the risk of endometrial cancer. And that's really important, because endometrial cancer is on the rise in this country. And there's been some emerging evidence that menopausal hormone therapy, likely because we're protecting that endometrial lining, seems to decrease that risk of endometrial cancer. So it would not be a contraindication or a reason not to use that whole body hormone therapy. We just want to take it, again, as another piece of the puzzle. All those different things: family history, endometrial cancer, breast cancer, sleep, brain, cognitive function,
everything, which is why it's an individualized decision. I also just want to say about the local vaginal estrogen that we are working to get the black box warning off of the vaginal estrogen. So basically back in 2002, after that big study, all estrogen products were put a black box warning, which is like the biggest warning you could put on, was put on vaginal estrogen. So what do you say to those people who decide, okay, I'm going to take vaginal estrogen, and then they get this black box warning? What should they do?
In fact, I tell people proactively when I write it, just so you know, there's this black box warning. We're actively working to try it. And this has been an effort over years that other people have tried as well. I guess there's only one case of the black box warning ever coming off something, correct, Donna, with the FDA. So I tell them ahead of time, you're going to see this black box warning. I promise you it's not true. Vaginal estrogens do not increase your risk of breast cancer, clot, and stroke and dementia. You're going to see it there. And I promise you it's not true. And there are more benefits than there are risks. So I tell people every time I write it.
Great. Okay. Heather B asked this question to you. Will having only one ovary impact my postmenopause years? About 32 years ago, I had an ovarian cyst surgery. The cyst to destroy the ovary. I'm at postmenopause now, age 58, and I'm considering HRT. I'm already using vaginal estrogen. What can I expect if I'm not a candidate for HRT?
So when we remove one of the ovaries, it really doesn't seem to impact our hormone levels much during our reproductive cycles and really in menopause either. We know those ovaries, even after we go through menopause, still produce like about 50% of our testosterone. So I would say intuitively, there might be a little bit lower testosterone, but it might not be significant. It really shouldn't change management of any of the hormonal options, any of the management at all. So I don't think there's any concern with not having an ovary, and it shouldn't really change that trajectory or really even the symptoms, unless perhaps there's maybe a small impact on our testosterone production.
Great. Okay. The next question is, should you skip your period on the birth control pill to keep the same level of hormones consistently?
It's completely, I would say, choice, no matter how old we are, whether it's our teenagers or 20s or 30-year-olds, whether you want to have a withdrawal bleed periodically, because it's just a mimicked period. So I will very often in the perimenopause either skip cycles altogether or do a cycle, say, every 3 months. And the reason I do that is sometimes with these prolonged pills, you can get this annoying breakthrough bleeding or spotting. It's not a difference in the hormone level, but it can be super annoying for people. So I sometimes find splitting that difference in every 2 or 3 cycles, having a scheduled withdrawal bleed for 5 to 7 days, that hormone level does drop. They could be at risk for a migraine or not sleeping as well, but then they'll shed that lining, reset it, and start up again. So there's no medical reason you have to do it. I just find for some people, they can't go continuous without spotting. But I mentioned sometimes using that IUD can be a really nifty way to kind of get that lining super thin and then get away with a really low dose continuous pill. Great. Because, right, why have any peaks and troughs, and why have a week with your hormone level that hits the ground?
Right.
You don't need
That's
to.
what you're trying to avoid. You're trying to avoid that, and you have it go across. Okay. All right. Anonymous asks, 40 studies concluded that oral micronized progesterone provides endometrial protection if applied sequentially for 12 to 14 days a month in a dose of 200 milligrams a day for up to 5 years. What happens after 5 years? Is it still effective for uterine protection and for the brain?
So 2 parts. Number one, they're just coming up with a disclaimer because the study only looked for 5 years. So they do this a lot. And they say, like, it's been protective for up to 5 years. And sometimes we say these things from a study because that was the study period. So we understand
it was a particular study.
Any of these will be, like, when we say it's been shown to be protective for up to 5 years. They've done lots of them, say on ospemifene, and like after 3 years, it doesn't seem to stimulate the endometrial lining, something like that. That means they only looked at it for 3 years. So you have to, again, extrapolate. Yes, we think that's protective. That's a cyclic regimen versus a continuous of 100 milligrams all the time. In America, we don't do a lot of cyclic cycles of menopausal hormone therapy quite as much as, say, in Europe. But that 200 milligram dose, 12 to 14 days a month, is an option, or 100 milligrams nightly is an option. Both of those work. I don't think we have any data that says progesterone is helpful or protective for cognitive function. In fact, as we talked in the beginning, there's some concern that estrogen plus progesterone arms might have a slight increased risk of dementia. So I wouldn't tell someone that we have evidence that I'm aware of the progesterone is protective for brain function, but I would say yes, at those doses, we understand that to be protective for endometrial cancer, to counteract those estradiol effects on the uterine lining. And even for people who are at risk for endometrial cancer, we sometimes do cyclic progesterone that way, or an IUD proactively. For example, obesity and hypertension and metabolic syndrome, those are all risks for endometrial cancer. So sometimes if people have unscheduled or postmenopausal bleeding, we'll either treat them with progesterone to protect the endometrial lining or even put an IUD in. So really useful thing, and we think protective longer term. It's just that a study obviously only looked for a 5-year period.
Got it. One question from me. How is it that estrogen alone, so say a woman does not have her uterus, estrogen and progesterone showed a slight increase in breast cancer, but estrogen alone showed no increase in breast cancer. But then it was sort of the opposite. So would you say maybe that it's the progesterone that maybe is the cause of the breast cancer versus estrogen, which everyone
so that's what they think. And I'll say there are a couple caveats here. And the estrogen alone, interestingly, perhaps there was even a decreased risk in breast cancer. And nobody,
yeah. Mm-hmm.
So not only did it not increase, but perhaps a decreased risk. So we think absolutely that it's perhaps a combination of the estradiol kind of promoting. And we don't think, most people don't think that hormone therapy causes breast cancer, but that it could be kind of a promoter. And we think there's something about that combination. There's something about the progesterone. So even these other newer types of progestins, like the micronized progesterone, because that study was on Provera, which is kind of an
old 2002 study was on Provera, not micronized.
Now we have micronized, so we're kind of again left extrapolating. And if someone's using an IUD to protect the lining, intuitively to me, that's a lower systemic dose because it's most directly to the uterine lining. So we don't really know how to extrapolate that, but we think that it's probably the combination.
Mm-hmm.
These studies weren't perfect, is what we learned.
Yeah, without a doubt, without a doubt. Okay, we're going on to testosterone. And so the question is, if you're taking testosterone gel for reduced libido, but you're also taking estradiol orally because you are not absorbing well with the patch, are you defeating the purpose of the help for libido from the testosterone, as oral estrogen can lower libido?
And I would say really good question. And obviously that person has a really good understanding of kind of when we take the estrogens orally, it actually changes our sex hormone binding globulin, which competes for like the free testosterone. And so it does impact our free testosterone a little bit, but I would say it doesn't counteract it. It might make that testosterone a little less effective, just like people might be familiar that oral birth control pills can sometimes suppress our testosterone a little bit. That's the mechanism of often how they help acne and help hair growth and help mitigate another, a bunch of other symptoms from our androgens. Another one that's really tricky for people is many people around the time of menopause notice that they have kind of that central weight gain, where adiposity goes more central. It's more the male pattern of fat deposition. And when somebody really wants testosterone for the libido, or if they've read about kind of sense of well-being or muscle mass, I explain to them, if we give testosterone, we're kind of increasing that tendency of those androgens. It's often a trade-off with these things. You might get a little increased libido, but you might get more acne or hair growth. And, if you take an oral estrogen for your sleep and your hot flashes, it might impact your free testosterone a little bit. So it's all very complex. I would mention to that person, they're very, very expensive, but that estradiol ring, the fem ring, is a ring that goes in the vagina 3 months at a time. And that could be a way to get transmucosal absorption of the estradiol rather than the oral route. Because even more important than mitigating that testosterone impact, when we take estrogens by mouth, they slightly increase our risk of clot and stroke. But when we take it through the skin or through the mucosa, we don't think there's a significant increased risk of clot or stroke. So something like the fem ring for that person with testosterone gel could be even better management, perhaps.
Mm-hmm. Mm-hmm. This is not a question from the audience, but because we're talking about testosterone, can you talk to us about pellets?
Yes, I can talk to you about pellets. So, pellets in general are, first of all, not recommended by the Menopause Society, but I'll explain why that is. When we look at the pharmacology of any medication or any hormone, we have kind of an absorption rate, and then we kind of have a half-life where things kind of hit the floor. And so when you look at different ways of giving something, whether we take a pill by mouth, and I explain this to my teenagers taking birth control pills, we get a peak and then it kind of falls and then we take a peak again. Whereas if we have a birth control ring, we get a more steady state absorption. Okay. If you do testosterone by a gel every day, you're going to get kind of a little peak and a little gel, like you're going to do this. If you do an injection once a week, you're going to get a peak and then it's going to fall for a week and then you're going to get a peak. If you do a pellet, you're going to get the sky high level and then it might be in your system for 3-4 months and we cannot get it out. So I have personally taken care of plenty of people that have come to me from other places where they've put pellets in and their testosterone level. So a normal level for women is typically up to about 48, 50. And I've seen people at levels of 200, having increased hair growth, permanent deepening of the voice. I saw someone recently by one of these centers who was given a testosterone pellet and was going to the center to get hair removal for all of her chest hair. Now, all of us on this call probably understand that's really ethically dubious to have someone's testosterone so high that they're then having hair growth, that they're paying for laser removal, right? So the reason I don't like pellets is, number one, I have no idea what's in them. They're not FDA regulated. We don't know how they'll be absorbed. We can't get them out. We see sky high levels and they're typically not, I mean, they're not covered by insurance either. So someone's paying their heart. So that's why I don't like them. Is that enough?
That's totally enough. We have 4 more questions. So let's get to them because we really would love to answer everyone's question today. And I know I got sidetracked.
We're both those fast talkers.
Right, exactly. Okay, next question. What to do about UTIs after sex? Besides the recommended hygienic, fractional laser, hyaluronic acid, nitrofurantoin pills as prophylactics, estradiol cream, D-mannose is a combination that is sure-proof.
So nothing 100%. I loved this question. This person's obviously struggled a lot and tried a lot of things. I think there's reasonable data, although Dr. Jen Gunter would disagree. I think people should void after intercourse. That seems to sometimes get some of the bacteria out of that urethra. We have a shorter urethra in women, so we're probably at higher risk for urinary tract infections anyway. The vaginal estrogen of some sort that we talked about reduces that risk by about 50%, so not 100%. D-mannose, I looked at that data earlier today. It's really been all over the map. I tell people using 2 grams of D-mannose has seemed to be somewhat helpful. It doesn't seem to be harmful. There's a small chance of diarrhea. That's something that there's some evidence-based data behind, but it's a little murky. The nitrofurantoin, a pill after intercourse, is something that we do for people with recurrent postcoital infections. So I would say those 3 are the ones that I would stick with. Hyaluronic acid, a good lubricant so that there's less abrasion makes sense. So a lubricant makes sense. Make sure someone's comfortable, make sure they have normal arousal, they're using a vaginal estrogen, they're avoiding after intercourse. And that's what I say. And then ultimately, if there are a lot more infections, they should be seen by a urologist. Sometimes someone can have a stone or a little ureteral reflux.
Right. And there are urogynecologists, right? Is that what we could see?
Yeah, both either trained by urology, like originally urologists, or gynecologists that do specialty training.
Great. Okay. Next question. What does vaginal dryness feel like? Does this mean during sexual intercourse or just in general? Just wondering how to know when to start topical estrogens.
Yeah. So it can be really subtle. For some people, it can just seem like a little bit of irritation, a little bit of discomfort, even with the exercise or with their clothing. Some people will report like with intercourse, almost ground glass or sandpaper, really uncomfortable, sometimes even a little bit of spotting after intercourse. So I would say it can range from totally asymptomatic to awareness of some dryness, less discharge, less physiologic discharge. And we have other benefits from using low-dose vaginal estrogen. So I would say have a low threshold if you're noticing any symptoms, even with sexual activity, even, yourself, that there are good benefits. Don't wait. There's no reason to wait.
Right. Basically what Dr. Noble and our doctors say is, start it and keep it for life, right? Just sort of, you keep going with it. And because it's chronic and progressive, so it doesn't get better. It only gets worse. So
I will say are on hormone therapy, like systemic levels, and they really don't have any symptoms or any change in sexual function at all, they might not want that as well. They might not need it as well.
Great, perfect. Okay, next question. Will local estrogen help urge incontinence if you have a prolapsed bladder? Is this appropriate even post-menopause, i.e. early 60s with no other dryness or reasons for local therapy?
Absolutely.
Okay, then there's an osteoporosis medicine. Does it make it worse?
What was the last bit about the osteoporosis medication?
Because does osteoporosis medications make urge incontinence worse or better?
Yeah, I'm not aware of that connection, but there's no concern about that vaginal estrogen. It does generally, it's quite helpful with urinary urgency. And sometimes even with that kind of drop bladder or cystocele and prolapse, because I tell people it kind of improves that blood flow and collagen and elastin. So even those symptoms of prolapse or cystocele, when people feel like they're not emptying completely, can sometimes be a little bit improved with the vaginal estrogen.
And also I would say that at our Menopausium, we had pelvic floor physical therapy. And so that would also, I think, be in conjunction with that, correct?
Very helpful.
Okay. Do energy levels and sleep problems eventually improve, or is it going to stay this way forever?
Tough question. A lot of it does improve, but it's really difficult to predict. Some people can see their hot flashes and get better in 2 to 3 years. Other people, they can be present for up to 20 years. Some people will have sleep issues kind of their whole lives and never really notice a huge difference. But when it really does take a dive around menopause, sometimes that improves a little bit. There's a lot of kind of modulation even in our brain function and sleep. But the sad thing is for some people, they will suffer for decades with changes in sleep, changes in sleep quality, REM sleep, deep sleep, and estradiol is the single best treatment for that.
And then for other people, there are some other medications for sleep. And I encourage people to go to our sleep talk, menopause talk with Dr. Fiona Baker. And there were some medications that were also talked in there. I know gabapentin and trazodone and other things, because I think one of those things is like sleep is so important for mood and it's so hard to tease things out. So, and also CBTI. So that's, cognitive behavioral therapy for insomnia. It's not just like, that's not just sleep hygiene. It's actually like skills for sleeping.
I would add to that, sleep has so much of an impact, not on those things you mentioned, but even our metabolism and our weight and our cortisol level. And so some of the medications that are non-hormonal that get to the root of those hot flashes can actually improve sleep also, not typically as well as estradiol, but some of the newer medications like fezolinetant, which acts centrally at the brain at the thermoregulatory center, which really we think just helps hot flashes, that can in turn help sleep a little bit. Same with some of the SSRIs and some of the other medications that can help with sleep by acting at those hot flashes. So they're non-hormonal options, as Donna mentions, definitely.
And the other thing is, we know that like a lot of times the sleep disruption is like you're about to have a hot flash a minute later. It's that thermoregulation. It's even if you don't necessarily feel like you're hot or feel, many times you do, but and then it really does suck to not be able to sleep. So to that person who wrote in, we hope you get to some sleep. Okay, one last question. I can't believe, we have one in review. Let's see if we can get to it. Okay, combination of endo and menopause symptoms. So I guess endo.
Endometriosis and menopause symptoms, yeah.
Okay. How to know which is which? I have an IUD and endo symptoms increased a bit, but meno symptoms went down. Still sleep problems and meno belly.
Yeah. So one important distinction is those IUDs can be really helpful for endometriosis and abnormal bleeding and endometrial protection, but people get confused because they now hear they're good for up to 8 years. They're good for up to 8 years when we use them to prevent a pregnancy, but that progesterone level really does drop at like that 4 to 5 year mark. So if someone's using one of those for endometriosis, it does make sense to change that out earlier. So at that 4 to 5 year mark with an IUD, if someone feels their endo symptoms coming back, that would be a really good time to probably get a fresh one because they'll get more benefits from that localized progesterone. That might help a little bit, whether the endo seems to be getting worse or whether they're having menopausal symptoms. And then if done right, you can absolutely treat the menopausal symptoms with hormone therapy, even in the setting of endometriosis. And in fact, a lot of the things that work for endometriosis, like low-dose birth control pills, that IUD, actually work very well for the perimenopause. So I don't think any of that's mutually exclusive, but certainly confusing, because people can have hot flashes. We think there's a lot of research ongoing with endo right now. We think there are a lot of inflammatory symptoms too. So sometimes people can almost feel like, febrile, really fatigued, some of these other symptoms when their endo's coming back, and that can mimic some of the symptoms we have in perimenopause. So complicated, but shouldn't impact treatment. In fact, it's aligned. A lot of the treatment is aligned and not counterproductive, if that helps.
Mm-hmm. Okay, great. So there's another question, but I think we're going to maybe answer that question on through our Ask the Expert. It's about Veoza, safe to term, safe. Is it safe long term? And I don't know if we know the answer to that because it's a new medication. So Veoza is what you said before, was phenylenediamine. Is now we actually know why we have hot flashes, right? So again, I think we can answer that another time. So Dr. Noble, thank you so much for being here. We had so many questions, so many great questions. And I think what I got from this is that people are definitely more educated. People are asking really sophisticated questions and really, diving in. So I think that's amazing.
Well, it's a pleasure for me. I don't know if you all know, but I've known Donna for over 20 years now, right? 20, 30 years since we were babies. So it's always fun for us to spend time together. And I hope we answer some of your questions. It's a pleasure. I'll sign off so you can do your survey.
Yep. So we have our survey going up. And I also just wanted to let you know that we have our next menopause talk in July. It is with myself and Dr. Lisa Weinstock, who is a psychiatrist who I work very closely with. And so you can sign up there. We're going to go over CBT skills, which is cognitive behavioral therapy, and medication. And it really just, hold on, for some reason it's sort of going and making, okay, I think that everyone is getting that survey, but it's doing something weird. So if people can just sign up, that would be great. Spread the word. We want to thank Robin Noble. We want to thank you all for joining in. We hope that we were able to answer your questions appropriately. Please feel free to continue to ask us questions through that Slido app. If there was something that you learned and you're thinking about right now, you can go in and ask us questions. We're going to start using those as really a jump off point for different program areas. We really are very concerned and want to hear from you guys about what your questions are. Please visit our website, letstalkmenopause.org. You can donate. We are a nonprofit, and you can watch all of our past menopause talks.